presentation. My case is about a 73-year-old female patient who had an arterial hypertension, but besides this was healthy. She presented in a primary care hospital on January 28 with progressive dyspnea and angina since 3 days. On ECG, she was in AFib, tachycardic, and she had ST elevations in the inferior leads and T-wave inversions in A1 and AVL. Her blood pressure was 80/60, her heart rate, as I said, 110 per minute. She was respiratory stable with a peripheral oxygen saturation of 98% under 3 liters of nasal oxygen, and she had cold and sweaty skin. So the diagnosis of a STEMI of the inferior wall was made, and the patient lactate was not available. As you can see, her high sensitive cardiac troponin was elevated with more than 3,000 nanogram per liter. She was in acute renal failure. She had an increased leukocyte count and elevated liver enzymes. On a TTE, which was performed there, they saw ventricular septal defect with a left to right shunt, a high-grade eccentric mitral valve regurgitation without any evidence of papillary muscle rupture. Due to this mechanical complication and cardiogenic shock, the patient was transferred again to our center, and there she arrived around 12 hours later on January 29 at 2 a.m. At arrival in our department, the patient was awake. She was spontaneously breathing. Her blood pressure was stable on this level, like 90/60, her heart rate 100 per minute. She was on low-dose dobutamine and low-dose norepinephrine, and she was completely pain-free. Also in our department, of course, the high-sensitive cardiac troponin was elevated, but without any relevant change over the course of time. And on blood gas analysis, she was kind of stable with a normal lactate and rather normal pH. She was hyperventilating. Oxygenation was good. And she remained stable at this level during the whole night. So we decided to perform coronary angiography early in the next morning. First, I'm going to show you some TTE pictures showing the ventricular septal defect. And on the right side, you can also anticipate the mitral valve regurgitation. Unfortunately, I don't have a better picture due to the emergency situation, but you can see that there's no papillary muscle rupture. Now I show you the coronary angiogram, and you cannot see the occlusion site, but you can see that there's an RIVP occluded. And the patient had a 3-vessel disease, also with high-grade stenosis of the circumflex of the LAD and of the diagonal branch. And on the right side, you can see, it's a picture, you can see the retrograde filling of the RCA. Since the patient was rather stable, it was decided, but she was in shock, it was decided to put her on ECLS support with the VA ECMO implantation by the cardiac surgeons. And it was decided not to perform surgery directly, but to do it in 7 to 8 days, together with a revascularization and also a mitral valve operation. Here you can see the patient on our ICU. She was still awake. She was spontaneously breathing on ECMO support with like 4 liters. And you can see that she didn't have much own cardiac output on the right side of the picture. But the patient remained like this for several days. After 3 days, a colleague performed a routine TTE examination, and I really checked all the charts. It was a routine TTE. The patient was completely stable. She didn't have any lactate. And you can see that there's a hemopericardium with a maximum of 4 centimeters, means a large hemopericardium due to a contained rupture of the free wall of the right ventricle with an almost collapsed RV. And on the right side, you can also see the aneurysm. We had a long discussion with the heart team and the patient, but we decided, since the patient really wanted to have the surgery, we decided for ultima ratio surgery. During the surgery, the surgeon saw a massive acute myocardial infarction with an acute aneurysm, a contained rupture of the posterior wall, a large ventricular septal defect, and also marked necrosis of the posterior medial papillary muscle. So they performed the mitral valve replacement. They closed the ventricular septal defect with a large bovine pericardial patch. They closed the aneurysm with a door procedure, and they made a saphenous vein graft to the LAD. I have some pictures of the surgery here. On the left side, you can see the mitral valve regurgitation without any large flail or something, but the papillary muscle was ruptured, and you can also anticipate the aneurysm. And on the right side, you can see the mitral valve after mitral valve replacement. Unfortunately, after stopping the heart-lung machine and after the surgeon gave protamine to get her off the machine, they had a problem with a large thrombus on the mitral valve and in the left atrial with complete blockage of the mitral valve. They had to open her again and to perform thrombectomy. And on the right side, you can see the final result. Unfortunately, directly after the operation, the patient developed disseminated intravasal coagulation. The closure of the sternotomy was impossible due to severe bleeding. So we took her with open chest to the ICU. And also there, she had massive bleeding and need for transfusion. So unfortunately, we had to decide to de-escalate therapy due to futility. And the patient died. I decided to present this sad case because I think there are many take-home messages, things to learn, and also points to be discussed. The first thing is that we had a patient with at least 2 mechanical complications, namely a VSD and a contained rupture of the free wall, and we also with ischemic MR. I think one problem, and we can discuss it later, is that there was a transfer of a patient with cardiogenic shock, which of course should be avoided. I don't think that in this case it would have changed anything. However, we shouldn't transport the patient with cardiogenic shock 2 times. It would have been better to bring her directly to a tertiary center. It's really important to perform TTE in patients for the diagnosis of mechanical complications, and also to perform physical examination, because you might have noticed that I didn't present any reports of a systolic murmur. This was because it was just not documented that the patient had a systolic murmur. We can discuss the role of VA ECMO to stabilize patients and as a bridge to surgery, timing of ECMO and timing of surgery, of course. And it's really important to notice the extremely high mortality rates in patients with mechanical complications. Now I'm at the end of my talk, and I'm looking forward to the discussions. Thank you very much.
Thank you so much, Janine, for this excellent case. And I'm now glad to pass the word and the floor to Joseph to lead the discussion on this case. Joseph.
Okay, thank you, Janine, for this excellent case. I think ventricular septal defect has drastically decreased in the reperfusion area from 1 to 2% to less than 0.3% currently. But in spite of significant technological advances, the prognosis remains poor. Severe right ventricular dysfunction and cardiogenic shock are poor prognostic signs. Mortality rate in patients with cardiogenic shock is nearly rated or 80%. And mortality in patients who are treated conservatively is nearly 100%. Therefore, intervention is the recommended approach in all of these cases. Also, the early surgery is associated with a high mortality rate. It is often because it is an urgent procedure, and therefore sometimes surgeons know that if they delay the operation several days, they can repair better. Therefore, the patients who remain stable after several days for sure have a high survival rate. And I understand that you try to get the intervention later. And the ESC guidelines recommended in the last guidelines that the patients with severe heart failure that do not respond rapidly to aggressive therapy to be operated immediately. But if the patient will respond to therapy, the intervention could be delayed. Let me ask you about in the last years, percutaneous closure has been an alternative approach. Did you consider this possibility in your team when you have this patient the first day?
Yeah, thank you very much. Very interesting question. Unfortunately, there are no randomized data comparing the surgical and the interventional closure. There are only case series of interventional closures after ventricular septal defects. And also in this case series, mortality rates of patients with cardiogenic shock were extremely, extremely high. And we also know that there are some technical issues with respect to this interventional closure. So the occluder systems are often not made for this kind of ventricular septal defects. And our experience is that it's not too easy to perform. So to be honest, during the last, we have interventionalists who are able to do that, but in the last years, we tended more to operate patients. We have done one or two, but in general, we give the patient to the surgical department to let them operate, especially because also in this case, the patient also needed bypass surgery. So it was a combination procedure. So we decided in this case to perform surgery. Unfortunately, as you said, the surgery for this patient retrospectively was a little too late. But as you also said, the surgeons are extremely reluctant to perform an early operation because they know that the tissue is very soft and very necrotic. It's very difficult to place sutures and to fix the ventricular septal patch if you do it too early. That's why we took this approach of waiting and then the surgical procedure, which unfortunately didn't work in this patient because she developed this extension of her pathology, unfortunately.
To this, I wanted to add as well, Josef, what we saw that the ventricular septum defect was very close to the apex. So it would be fairly impossible to put a closure device over there because there's no landing zone towards the apex. So it will, the device would certainly rupture the rest of the ventricle when you put pressure on it.
Yes, so, but on the other side, it has been described that posterior inferior rupture are more accessible for percutaneous. This is why I asked this. Yeah. But in fact, this was a catastrophic scenario because the patient had acute MI, complicated with ventricular septal defect, significant mitral regurgitation, free wall rupture, and shock. I think the probability of survival was really extremely low. But also there were some aggravating factors that we can comment because highlights some challenges. The first, that the patient did not consult until 3 days. This means that we fail to transmit the patients to consult early when they have a typical chest pain. But also, the second is that the echocardiography was not performed at the first center. And also our messages for the last years has been patients with acute heart failure, de novo, or with hemodynamic instability should be performed echo as soon as possible. And probably we could save time because every hour you add, in this case, probably the rupture is greater and the hemodynamic situation is even worse. And the third also is that to transfer to 3 centers. Also, we should establish a network of shock patients and transfer patients with shock to the heart center reference as soon as possible, not waste time to a secondary patient.
I have a question for Arsen. Dr. Wistik, in your center as head of the Department of Heart Failure, would you consider this patient for transplant?
Yes, but in the COVID pandemic era now, the transplant program was stopped, at least in our institution, so we could consider the patient for, as it was done in Leipzig, for prolonged ECMO or for advancing to the LVAD as a bridge to transplant. So normally, yes, it would be listed for urgent transplantation. However, in the situation when we need to deal with COVID pandemic, the transplant program for the moment is not working.
I have also a question for Janine again. Janine, you say the echo was a routine echo. Are you performing routine echo every day in patients on ECMO? That's my first question. And secondly, considering ECMO in a patient with a ventricular septum defect, how did you deal with potential pressure overload to the left ventricle due to afterload increase on ECMO?
Yeah, two important questions. In patients on ECMO, we indeed perform a quick TTE every day, at least once per day, because we're afraid of complications and also to assess volume status and so on. The second question, it's very important, the problem with afterload increase with the ECMO. That's why we did, in this case, we decided to implant the arterial cannula in the axillary artery and not in the descendants aorta, because we were afraid of this afterload increase.
Exactly.
And Janine, is there an explanation for why this early thrombosis during the operation for this patient?
I called a consultant of the surgical department to ask him this, because I'm not too much into this protamine thing after operation, because I didn't know how they make the dosage of protamine. And he explained me that if they go off the heart-lung machine, they need to give to some extent protamine, because they have to do the surgery with an activated clotting time of like around 500. And for ECMO, you need much less. You need still some increase in activated clotting time, but not 500. And if you leave 500, you cannot go off the heart-lung machine. So they need to give some protamine. And the problem is well known that the exact dosage of protamine is very difficult to find. And if you give a little too much, especially if you have to replace a valve, then you have the problem with thrombosis. You might have. It's a very difficult decision for the surgeons. That's what I was told, at least. But he also said that it's important to think whether or not you really have to replace the mitral valve in this case. But she had such a necrosis in the papillary muscle that they couldn't fix it without replacing the valve. So I think many complications due to this massive AMI that at the end you could not decide correctly. Whatever decision you took, it took you into other problems in this case.
Okay. Thank you, Janine. Thank you, Joseph, with this. And I'm now happy to pass the floor to Professor Arsen Ristic from Belgrade to discuss his case. And let's find out what this is about. Professor Ristic.
Thank you very much. It's a great pleasure to present the rather complex case on cardiogenic shock in myocarditis. Which is fortunately not such a frequent clinical scenario, but could be certainly rather complex to resolve, and it is a part of our clinical everyday practice. Myocarditis is defined as inflammatory disease of the myocardium, and for the etiological diagnosis, we certainly do need, in addition to histology, also immunological and PCR workup, and this is the focus of our presentation. So the balance between the risk and benefit of the diagnostic procedure and development of cardiogenic shock in a patient with a fulminant myocarditis. So etiology of the disease in our area is mainly due to infection, and in the current COVID pandemic, we also see up to 20% of cases with COVID myocarditis, but more recently also a substantial proportion of patients with cardiotoxicity due to neoplastic drugs like checkpoint inhibitors. And also all over the world, there's a trend in increasing recording of cardiogenic shock in myocarditis, most probably due to the more wider availability of mechanical circulatory support and availability of those patients that do survive the cardiogenic shock in myocarditis, in contrast to the previous time when without mechanical circulatory support this was not possible. So our case presented for 4 years ago in the age of 53. He had previous pneumonia, so after a respiratory infection, he developed acute chest pain. There was still a fever, and on admission, we recorded increased troponin that continued to rise, also with heart failure markers and with NT-proBNP also rising from 3,450 to the levels more than 8,000 picogram per milliliters, with still signs of pneumonia in the chest X-ray and in echocardiography and in MRI, advanced systolic dysfunction with some regional valve motion abnormalities, and with confirmation with late gadolinium enhancement that this overt progression to heart failure was probably due to the clinically suspected myocarditis. And fulminant presentation of the cases, although life-threatening for the patient initially, and also imposing a rather complex situation for management to the intensive care unit teams, is paradoxically accompanied with a good prognosis, as it was also finally the case with our patient, except cases with giant cell myocarditis that are still also presenting with fulminant presentation, but have a rather severe prognosis. In differential diagnosis, there should, of course, in a fulminant presentation, acute coronary syndrome should be excluded, and in our case, it was also promptly done, not only according to the typical ECG changes that are different in contrast to the pattern of the ECG changes in acute coronary syndrome, but also having the possibility to promptly do additional imaging like echocardiography and MRI, depicting what is an additional valuable information above the echo data, which is implying the structural changes in the myocardium and subepicardial localization of late gadolinium enhancement was our guide to the further diagnostic evaluation. And if according to the ESC consensus, which is more than 7 years in practice, more than 2 criteria from different categories of clinical presentation, imaging, and findings in those categories are indicated for histological confirmation within the myocardial biopsy, having in mind that all other causes of unexplained heart failure are previously excluded, as it was the case in our patient as well. So we follow this algorithm as we do in every clinical case, and we did invasive diagnostic procedure. We did the coronary angiography that did not reveal any significant coronary artery disease, and we proceed with femoral approach for endomyocardial biopsy, taking samples for histology, immunohistochemistry, and PCR, which is a standard of care in the moment. And if you don't have all those 3 diagnostic tools, then the diagnostic value of the procedure is not appropriate. However, even when we completed the procedure, there were no signs of any complications, and the patient did not have any pain or any complaints. But 10 minutes after, a severe hypertension, tachycardia, and progressive worsening of the condition of the patient appeared, and we did a prompt echocardiography, and the patient was still on the table. We could, from the lateral view, appreciate the large hemopericardial, which was causing in this already hemodynamically not too stable patient prompt evolution of cardiogenic shock. We were able to stabilize the patient with immediate drainage of the hemopericardium and auto transfusion of the blood into the large femoral sheath. And we were lucky enough that the perforation and the bleeding stopped after this maneuver, and the patient could be stabilized. So patient with advanced heart failure with rather severe hemodynamic condition managed to survive this rather frightening complication in the cath lab due to the prompt relief of the cardiac tamponade. And in patients with myocarditis and with advanced heart failure, hemodynamic instability should certainly be the first treatment target, and heart failure syndrome as well as the hemodynamic instability should be treated with mechanical assistance, which whenever possible should not be the long-term device. However, as well as its cardiac transplantation, that should be deferred to the further stages of the disease if there is no recovery under treatment or spontaneous recovery of the patient. However, the diagnostic algorithm developed in 2013 is actually providing therapeutic implications of those procedures, and those therapeutic implications include the findings in our case when there are specific etiologies like giant cell myocarditis, like cardiac sarcoidosis, systemic autoimmune disease, but also eosinophilic or toxic myocarditis, or also important, as it was in our case, infection negative lymphocytic myocarditis. So the cases where you still have an active inflammation, but a negative PCR for all cardiotropic viruses, those cases do need immunosuppressive treatment, and they get better under immunosuppressive treatment, as it was the case in this series with fulminant presentations that patient recovered regarding the impaired systolic function, as also survival is quite different in fulminant presentation in comparison to the non-fulminant cases. So the solution of our case was also positive. So despite this terrible complication and frightening situation in the cath lab, in addition to the already impaired hemodynamic condition with fulminant myocarditis, the patient got his etiological diagnosis. He got the treatment according to the TIMIC protocol, also combined prednisone and azathioprine for 6 months, and we are following him for more than 3.5 years now, and his hemodynamics and echocardiography findings return to normal condition. He's back to work and has no major complaints. So this is the presentation of my case, and I'm looking forward for the discussion mainly about the balance on risk and benefit of the diagnostic algorithm in comparison to the progression of the fulminant myocarditis to the cardiogenic shock.
Thank you, Professor Wistik, for this fantastic case. I pass the floor now to Josef again to lead the discussion. Josef.
Thank you. Thank you for this interesting case. This is a typical case of fulminant myocarditis with acute heart failure. In fact, it was not really cardiogenic shock, but it was a complicated of the endocardial biopsy. But in any case, this raises the issue that in which patients we have to perform the endomyocardial biopsy. We know that nearly 50% of the patients with acute myocarditis have a benign course where they don't could be diagnosed with MRI and biomarkers, and probably it is restricted to patients with fulminant myocarditis. But there are different cases of fulminant myocarditis, those who are in cardiogenic shock and so others with severe acute heart failure. Regarding the rate of complication of myocardial biopsy, which is it's not very high, but it could be even 8% when we include non-high volume centers. In which patients we have to perform the endomyocardial biopsy, or this mandatory? What is your opinion?
This is a controversial issue, and this issue is differently managed in different centers around the world. And the answer to your question is highly depending on the center and the setting where the patient is treated. what is usually and internationally recommended is that complex and unstable patients should be referred to specialized, not only tertiary, but really specialized centers for cardiomyopathies, myocardial disease, and endomyocardial biopsy. So high volume centers do have less complications than the low volume centers. It is clearly showed in the several recent publications, as well as the ability of the operators to resolve the complications. So this patient would probably die on the table in a less experienced center presenting with advanced heart failure and major cardiac tamponade. Only if you have have enough courage and skill to promptly drain the blood from the pericardium and to do the auto transfusion, or if you have the neighboring cardiac surgeon which is promptly available to stop the bleeding in the surgical procedure. However, high volume centers do have less than 1% of major complications, and balancing the treatment benefit in patients with the potential therapeutic implications of the diagnostic procedure and the overall risk of the procedure, I think that then an overall majority of the experienced centers would still recommend the same diagnostic algorithm, despite having the clear low risk, but still the risk also for the major complications. However, if you do everything carefully, if you follow both the diagnostic and the protocol for performance of the biopsies, the risk is still much lower than the benefit of the procedure.
Professor Wistik, you mentioned during the discussion that the angio was combined with the biopsy procedure. Can it be that the fact that you give heparin during the angio procedure contributed to this complication?
No, we didn't give the heparin, and the heparin is usually routinely done, for example, for left ventricular and the myocardial biopsy. This was the case of when we did the right ventricle, but the heparin is not increasing the risk. The risk is purely technical issue, and several advances are available over the time regarding the soft types of the bioptomes, radial approach for the biopsy, combined imaging that is guiding your biopsy forceps, not only to prevent you from making a perforation, but also from to increase or actually to diminish the sampling error, to increase the diagnostic value of the sample. So this area is also experiencing substantial advances, especially regarding the combination of imaging and the procedure as well as the advances of the biopsy forceps. And over the time, high volume centers really do see less and less such complications. But there is an overall recommendation to refer the complex cases to the high volume center.
Mm-hmm. I have another question.
So heparin is not increasing the risk.
Another question, because biopsy gives a clear picture of which kind of cell myocarditis with the giant cell, lymphocytic or eosinophilic. However, it is really so important to have this diagnosis in cases of very severe inflammatory disease, because now I know that in COVID myocarditis, or at least presumed COVID myocarditis, they use immunosuppression. In fact, that they know that there is a virus infection. What is your opinion?
The discussion on this issue is lasting for several decades, and the working group on myocardial and pericardial disease is firmly keeping and repeating the the focus of the algorithm, which is actually should prove the active inflammation in the first step, and in the second step should prove or exclude the active viral infection. And in active viral infection, if you have a high number of copies and the active replication of the virus in the myocardium, immunosuppression should be contraindicated. We, of course, do not have studies with COVID myocarditis, but this should not be different in comparison to other viral infections.
Professor Wistig, to what extent are the overall biomarkers like troponin guiding you towards the fact that you have an active ongoing issue or that you have a stabilized patient? And how would you guide you in your strategy, not only diagnostic, but also therapeutic?
The levels of biomarkers are depending on the time frame where the patient is presenting. If this is an acute presentation, as it was in our case, and the troponin is increasing in front of your eyes, it is clear that an active inflammation is ongoing, and it is also putting some additional value to the invasive diagnostic strategy. However, negative troponin and even normal inflammation markers do not exclude the disease. So if the patient is coming after 3 to 4 weeks after acute infection, then the troponin can be normal. As well as CRP, which is always one of the tests in the initial panel, can be false negative in the early stages. You need to repeat the inflammation markers in the follow-up, and then have the proper information about the inflammation. So what is leading you is actually a clinical presentation, and if the biomarkers are increasing in front of your eyes, then it is a clear additional information telling you that your patient is not doing well.
Thank you.
Professor Wistig, I also have a question regarding left versus right ventricular biopsy, also regarding the question of Pascal before. Can you say some words about recommendation left versus right? I presume it will be a stroke versus bleeding risk. Can you explain a little bit more about this?
What is nowadays certainly more comfortable for the patients, having in mind that the radial approach is something which is enabling that your patient leaves the hospital on the day of the procedure, or actually on the morning of the procedure. Left ventricular biopsy is more comfortable and less risky regarding the risk of perforations. However, in patients with advanced left ventricular dysfunction with the potential to have some parietal thrombosis that you can dislocate during the procedure, even after proper imaging was recently done, then as you exactly pointed out, there is the risk of stroke or transitory ischemic attack versus the risk of perforation. So there are centers, or there are studies published on the diagnostic value of biventricular biopsy in comparison to either left or right, and it is depending on the pathology. So the best approach is actually to do the biopsy where the majority of your pathology is. If both left and right ventricle are equally sick, then it's you can choose according to the preferences and experience of your center. However, targeted endomyocardial biopsy is the procedure to come, and I believe that in the near future, a great majority of the biopsy procedures will be targeted by imaging.
Okay. Thank you so much, Professor Wistig, for this excellent case, and Joseph for this nice discussion. With this, I'd like to adjourn from this session by saying that acute myocardial infarction is the underlying cause of cardiogenic shock in 4 out of 5 cases. And indeed, if you're confronted with a free wall rupture, this could lead to a most devastating situation, as was presented by Janine. However, also sepsis and inflammation are common causes of cardiogenic shock. Myocarditis often has a benign course, limited course, but on occasions this might lead to also to a spectacular presentation of a patient with temporary or permanent dysfunction of the left ventricle. Whatsoever, whether it's ischemic or inflammatory as a cause of cardiogenic shock, pre-armed is pre-warned in all cases. So I hope that this session contributed to the pre-arming and pre-warning of our audience while be confronted with patients like this. So with this, I would like to thank the presenters, Janine Puss and Arsene Wistik, for their excellent cases. I want to like to thank Joseph Masip for leading our discussion, but most of all, I would like to thank the audience for being with us during this virtual session of the European Society of Cardiology meeting. And I hope that you would contribute more to our scientific endeavor during these sessions, and hope to see you also on new events and upcoming events of the European Society of Cardiology. Thank you so much for being with us.
Bueno, es un poco tarde, pero al final dos casos interesantes, ¿no? ¿Algo que quieran comentar, Poncho?
Doctor,
Ricardo.
pues nada más, bueno, ¿me escuchan?
Sí,
Pues
Poncho.
nada más, digo, este caso pues salió adelante porque se tenían en su momento todos los medios necesarios para poder tratar al paciente, digo, complicaciones isquémicas de ruptura tanto de la pared libre como el y luego insuficiencia mitral de origen isquémico severo que requirió cambio valvular, donde el paciente requiere de apoyo mecánico circulatorio, que en este caso lo hacen con ECMO, pero ahí se les se les trombosa la válvula que ponen. Digo, esto en el mundo ideal es lo que se hace con equipo adecuado y el paciente pues sale, pero desgraciadamente no en todos los centros se cuenta con ellos. Recordar, yo creo que cosas básicas podemos sacar de esto, ¿no? Recordar los estadios del choque cardiogénico, el artículo que revisamos desde el A hasta el E, las posibilidades de complicaciones a sospechar con el infarto, ¿no? O sea, saber cuál es el infarto que más se complica con ruptura de la pared libre o con ruptura del septum, complicaciones mecánicas, y recordar que, pues bueno, los dispositivos de asistencia ventricular, cuánto te dan por litros y minutos cada uno de ellos, ¿no? Recuerda que el mejor perfil hemodinámico tiene es el ECMO, y pues por lo tanto es el que pues se está utilizando en la actualidad para la mayoría de los pacientes. De ahí en fuera, no sé qué otra cosa, digo, para nosotros en nuestro medio que nos pudiera ayudar. Digo, tenemos el balón de contrapulsación, pero pues son pacientes que requieren de un team tanto de terapia cardiovascular y un team quirúrgico, así que pues le entren en el momento que se requiere y no vayan a poner contratiempos para poderlo meter y pues ahí salga adelante.
Ok, muy bien, Poncho. ¿Algo más, Ricardo? Eric.
Pues no, doctor, realmente nada más que agregar ahí. Pues, casi todo lo que dicen es en base a experiencia en grandes centros. Entonces, en relación a eso, pues lo mismo, nosotros las posibilidades que tenemos pues son muy, muy, muy limitadas. Y aún en eso, una de las doctoras comentaba que la mortalidad sigue siendo muy, muy alta, aún teniendo todos los dispositivos a la mano. Pues nada más otro ejemplo como el que nos había puesto la vez pasada de cómo sí se pueden hacer bien las cosas. Hay que conocer que existe eso, aunque de momento no lo tengamos disponible, pero es bueno estar expuesto a ese tipo de situaciones, al menos por este tipo de casos, y en su momento pues saber cómo reaccionar.
Bueno, ok, Ricardo, ya no te escuchamos lo último, pero muy bien. Pues nada, mañana es cumpleaños del doctor Leiva. Mañana va a estar el doctor Leiva conectado con ustedes para checar el tema a las 7 y yo me toca la clase, entonces me voy a conectar con los chavos del pregrado. Después de eso tengo que ir a la Secretaría de Salud a un caso como el que fue Poncho la otra vez, y de ahí me doy una vuelta al hospital. Llegó un paciente con exteriorización de marcapaso. Ya Eric está ahí al pendiente. Hay que hacerle un eco mañana. Por favor, ir adelantando un eco para checar las válvulas. Supuestamente tiene una fe baja. Entonces, pues hay que hacer eso, por favor, en la mañana. El plan es que el lunes partamos el postal con el doctor Leiva, pero pues mañana yo lo felicito. ¿Ok? ¿Algo más, chavos?
Sí, correcto, doctor. Ya me hablé con Eric y sí quedamos de mañana a hacerle temprano el eco.
Okay, perfecto. Mañana también, digo, yo creo que voy a regresar un poquito más tarde, pero de una vez para ir, ¿cómo se llama? Que presentárselo al doctor Leiva con los resultados y todo para a ver si de una vez firman la solicitud, ¿no? Para el recambio de la fuente.
Sí, doctor.
Ok, órale. Sale, gracias, chavos. Hay que ir sacando artículos. Yo también me doy la tarea de sacar artículos para revisar artículos la próxima semana, ¿no?
Correcto, doctor.
¿De acuerdo, doctor?
Ok, sale. Bye.
Hasta luego.